Firstly, as clearly and obviously the least clinically qualified person in the room, I'm going to be talking about some different things. I'll fight you on that one. I struggle to apply a band-aid to myself, so we'll leave that one until later. I've been working at EHS now for about 3 years as part of the Strategy and Transformation Office, which originally started out as the kind of the community paramedicine project and has since expanded to include a wider range of transformation projects. Now, because of that role, I tend to spend most of my time thinking about and worrying a lot about the future. So it's been quite refreshing for me to prepare this presentation because it's allowed me to reflect a little bit back on what we have been doing and the achievements that we've made. And you've heard about some of those over the last few days. Some of them you've been probably personally involved in, and maybe some of them that I'll be going through today will be new to you, and hopefully that will be a good thing. But as well as all of the things that we've done, whether those are clinical improvements, whether they've been process improvements, whether we've added new resources, whether we provide better support to our frontline paramedics and the work that they do, what to me on reflection was the most impactful is how our culture is changing. Our Chief Transformation Officer, Nancy Catani, as you've probably heard her say many times, that culture eats strategy for lunch. There's no point working in an organization developing clever strategies if we don't have the willingness in the organization, the culture to support that change. And since I joined 3 years ago, I feel very fortunate to have been part of an organization that is living some of those values around driving change through evidence-based approaches, supporting individuals through that change, and collectively working to improve our service day by day. So before I start, I'd like to thank the role that all of you play in that, in striving to be a better organisation every day. Now, the strategy of the organisation for BCEHS is kind of rooted in what we refer to as our action plan. For me, the value of the action plan was probably for the first time in a long time we managed to get the attention of our government and the need to make investment and a change in our service. And what helped, as we all know, what helps is a little bit of money to go along with it. Now, the objectives that came out of that action plan are not exactly rocket science. They're all things that we would expect to be doing. But, you know, doing them well is not necessarily as simple as it sounds. So the action plan itself was a 3-year strategy. We've literally just come to the end of year 2. So a lot of what I'm going to be talking about is where we're at today, what we've achieved so far, and the transformation that's been enabled because we put in some of the groundwork early on to kind of stabilize some of the foundations of our system. So I'm going to talk through each of the strategies in turn, very high level, just with some illustrative examples of what we've been doing. There are more educated, more informed speakers like Renee and Leon who will be following me with some of the details around this stuff, but I'm trying to paint a little bit of a big picture here around how everything fits together. So the first thing is our traditional role in being quick to emergency patients, those that have time-critical needs. So in order to do that and allow us to provide different clinical responses to patients, we needed to update the way that we triage and dispatch our resources. So we had been traditionally locked in a model where we would send an ambulance to every patient and we would take all of those patients to an emergency department. And we know from looking elsewhere in the world, from other jurisdictions, that does not provide optimum outcomes for patients. It's not a good response for our system as a whole, and it's not really a partnership approach for us as an EHS provider to be doing that with our hospitals and our health authorities. So first and foremost, we needed to figure out a way that we could provide different clinical responses. We were granted the regulatory change in 2017 for us to do that, but we had to start putting that into practice. So what we did after an extensive review of what has been done in other countries, how they've addressed the same issues with aging, demographics, the need to provide those different responses, is we developed our clinical response model. Now, what this does is that at the kind of bottom end here, it allows us to, from the point of initial 911 triage, to identify that there may be patients suitable for something other than an emergency department, and to try to connect them to the right resources, whether or not that's our own resources, or whether that's referral into resources provided by somebody else. And like I say, others will come and give a lot more detail around that. What I wanted to briefly touch on here is what we've done with our traditional ambulance responses in terms of categorizing them into 4 different levels of priority and what that's done to our system performance. So historically we'd had our resource allocation plan, which had done a good job of identifying the types of resources that we should send to different patients, but it wasn't really set up for prioritization. Our systems and the underlying thinking behind it was basically you go code 3 or you go code 2. And you can upgrade a code 2 to a code 3, but that's about as far as it goes. What this allows us to do is to have more granularity in our prioritization, but more importantly, use our resources more wisely, particularly when we start thinking about our first responder partners and the resources that they consume on medical calls. For most first responder organizations now, medical calls is the bulk of their work, and we wanted to make sure, as well as using our own resources wisely, we're using that of our partners wisely as well. So, in developing the clinical response model, we had what I felt was a pretty thorough clinical process led by John Talon and his team. Some of you, I think, were involved in that process. I think for me, the big thing here was how we had actually managed through a lot of the contacts that we had in other countries. We were able to pull some of their experiences, not just their systems, but also the results of their evaluations, their lived experience of implementing this kind of more clinically driven response model. And that's allowed us to refine the way that we triage these calls. So we implemented this May the 30th last year. So we've been running it for almost 10 months now. So we're starting to build a body of data and evidence as to what the impact of this change has been on our system. So at this point, most of our analysis has been to reassure ourselves that our responses are still timely, that we're prioritizing things effectively. We will, over time, obviously start moving towards more clinical outcome kind of measures and evaluation, particularly as we could start gathering more information through our electronic PCR system. So in the first 6 months of operating the clinical response model, we saw what we've, a pattern where about a quarter of our calls are deemed high acuity, time. Interestingly, we had been seeing quite a steep increase in the number of 911 calls we had been receiving as an organization. This seems to have temporarily flattened out a little bit, but we've seen this pattern in the past where we'll get a year or two where it doesn't rise and then it will continue and then it will rise again. Difficult to draw any conclusions from that, but it puts this into context, is that our performance in the last 6 months is broadly comparable to the number of calls that we've been having prior to that. So we can make that kind of comparison. Now, it's very challenging for us in a complex system to identify exactly what the root cause is for different improvements. There were multiple things that have happened during these 6 months. We changed our clinical response model, but we were also in the process of adding resources to our system. We were changing certain processes, both out in terms of our clinical care, but also in the background in terms of trying to get more accurate data that we could use for this analysis. But the broad results have been very positive. When we look at the highest acuity calls, we see generally an improvement in our responsiveness to these calls. but most importantly from my perspective is it's targeted the areas where we expected and wanted the biggest improvement. So here where you have the communities where we currently have our slowest response times, we have been able to make the biggest improvement by changing to our clinical response model, which to me says that we've done a better job of prioritizing the calls in those communities that perhaps have maybe not so many resources, or the resources have been further away, but through a better focus in our dispatch, we've been able to improve that. Now, the purple calls are always the headline figures, but they're a very, very small sample size. We don't get many of these. It's less than 2% of our total call volume. So perhaps a more indicative picture is what comes with the next category is our red calls, which are still those that are deemed time critical and definitely need to go to an emergency department. And all of these calls we immediately dispatch first responders because we know that time is critical. So these 19 of the 20 largest communities in the province saw an improvement in response times following the introduction of the clinical response model. So that to me I think is very positive. At least we know we didn't get any worse, and we know that we're doing a better job of matching resources to these patients. Now, as part of this change, we were very thorough in our evaluation. We've been watching metrics on a day-by-day basis since that change occurred to make sure that things are okay and that we could react if anything wasn't looking ideal. And this gives some kind of sense of what we see on a day-to-day basis. So we have variability, and we particularly have that variability in our purples just because the call volumes are so low. So on a day-to-day basis, this might only represent a handful of calls in the province. Because here we're looking at the metro-urban response times. But we've got very clear prioritization. The purples are generally, we get there faster than the reds, faster than the yellows, and the oranges and the yellows. And the other encouraging thing that I find about this particular analysis is really how stable this red line is. The difference between a good day and a bad day is not really experienced much by our high acuity patients. As it should be, it's experienced more by our lower acuity patients that don't have that same critical need for a timely response. Now, in an ideal world, all of these would be lower on the graph, but working within the resources that we have, we feel that the clinical response model has achieved the aims that we had when we set out with that change. Now, the work doesn't stop. There's been ongoing clinical reviews of how we assign those colours to individual NPDS codes in different patient groups, and particularly because we introduced NPDS version 13.1 at the same time, that introduced some new codes where we weren't really sure what the response level should be. And again, John and his team have done a great job of continuing that review and moving some codes down in priority and some higher in priority on the basis of the most appropriate response. So the biggest change that we made in January was that we took some of the new CARD 23 overdose subcategories, which we hadn't had any historical response information around, and we've now classified all of these at a higher level of priority, which not only gives them access to an ALS response where we have that, it also ensures that our first responders are automatically notified of these calls immediately and can get there on scene, because we know that this patient population can systematically underreport the severity of their situation, and we know that we are getting somebody who can be trained in the naloxone interventions as quickly as possible to that scene. So, speaking of first responders, some of you may be aware already, after 18 months study, we just had the Office of the Auditor General publish their report on BCEHS. It was a long process. They had a lot to learn, and we were changing very rapidly while they were doing that study, which they were trying to keep up with us. But one of the very valid points that they made in their recommendations was that as an organisation we should reconsider the way that we report on our performance, both in terms of timeliness and in terms of clinical care provided, to incorporate the role of first responders. We have a system-level response. We're not always the first organisation on the scene. We're not always the first organisation to administer some intervention for a patient. And all of that data that I just showed you is only what we do. So when you start thinking about, from a public perspective, from a ministry, from the broader health system perspective, we should actually be doing a better job of tracing the patient journey from the moment that they call 911 and what kind of services they receive along the way, either at the scene or subsequently within the health system. So we have historically had challenges sharing data between the different levels of government, with us as a provincial organisation versus the municipalities, the fire departments. But there's a real commitment from all sides now to improve that, and we're looking to see how we can do that both in terms of a real-time data sharing so that we can support crews collaborating at the scene, but also after the event how we can do more analysis and research around the impact of first responders on our overall system. So, like I say, I've covered off what I want to do around the lower acuity responses, and Renee and Leon will give you more detail around some of the specific strategies that we've got going right now. But I want to talk briefly about the third action plan strategy here, which follows on, I think, quite nicely from what Blaine was saying around some of the challenges we have in rural and remote BC in being able to provide a consistent service. So we know for a long time that we've had significant challenges in smaller communities, recruiting and retaining paramedics to work in those areas, and being able to maintain their clinical skill set with the local volume that they experience in those environments. And those things together provide significant challenges in maintaining emergency coverage in those communities. And that arises largely from our historical staffing model, our kilo shifts, our on-call staff, and how we maintain them. Now, what may on the surface be a rural and remote issue of maintaining coverage actually has much wider implications within our system. One of the first things that I did when I joined EHS 3 years ago was to do a complete workforce analysis, looking at how paramedic careers evolve, what they do, where they move, where we have staffing issues and so on. And it became very, very clear that what is often referred to as the paramedic spawning cycle is real. You know, paramedics, because we operate a seniority-based recruitment system, paramedics are forced to start their careers in the smallest, least desirable locations, where they have very limited ability to practice their skills or even earn a living. So we have people who struggle to survive, and their way of getting out is to progressively move up the chain or move closer and closer to the lower mainland where they could get full-time work. And this leads to definitely a suboptimal situation in rural and remote. We can't keep people, we can't maintain skills, there's very limited ability to mentor and develop those paramedics, and simply speaking, we put our brightest, newest, keenest recruits who've just come out of their training, and we put them in a place where they don't do a lot. And that's not really a way to motivate our workforce and engage them with a long-term paramedic career. But the unintended consequence of that even is that it creates problems for us in our urban centres as well, is that we have people who've been paramedics for many years moving to urban centres who have no idea what that's going to be like. That transition to a full-time career is challenging for them. And we end up with our senior paramedics working in environments where they are busy, they're working the most number of night shifts, they're dealing with the highest call volumes, and they're right next to all the other most senior people who have all the same experience, who are right next to our hospitals, who have all of the experience to know how to handle these patients. So we need to do something to change this. We need to create sustainable employment for paramedics in smaller communities so that those people who are at the end of their careers or even partway through their careers have career paths that can take them into these communities and they can bring their experience, their knowledge, their community leadership skills into areas where they can have a real impact. So that's my little soapbox, really. So community paramedicine was our first step in trying to achieve that. Basically what it says is, if we can expand the scope of what paramedics are able to do, if they can take on different roles in these communities, they can first and foremost contribute to the health services that people have access to in those communities, and secondly, we can provide something sustainable for paramedics. Now, the CP program has been running for a number of years now. It's kind of been growing exponentially as we grow the number of CPs out there. We've now got over 100 individuals who've been trained or are actively practicing in 99 different communities across the province. This data is some kind of interim data that's been published that kind of shows the number of patients we're interacting with. But to give you a sense of how quickly this is growing, this number here in September was 1,300. By December, it was 1,600. Similarly, the number of patient visits went to over 20,000 just within the space of a few months. So now that we're up to full staffing and we're getting people engaged with their health teams in each of these communities, working alongside the health authorities, the nursing stations, we're seeing some really big benefits to this program. And the benefits translate to us as an organisation as well, in the fact that the interim results are showing that patients who have been connected to a community paramedicine service are much less likely to call 911 as a crisis. And although this started off as a small patient population, there's been a lot of significant work done since, which is very imminently going to be published through the formal evaluation of the CP program. The statistical analysis around this shows that this is a real trend, that we can count on the CP program reducing the number of 911 calls from these patients. And there's further work to be done for sure in validating exactly what the extent of this is, and connecting with hospital data and admissions data and things like that, so that we can see what the ultimate health outcomes are for these patients. But again, another good example of how we have been able to take ideas from other places, implement them in BC, and make them work within our system. So, on top of the CP program, we have the same issue around our advanced care paramedics. We know that so many communities would like to have an ACP in their community to be able to support with those high acuity patients when they happen. The issue is that they don't happen very often. So how do you create a sustainable ACP role in a smaller community? Well, we have a research project going on right now with the University of Northern BC, where we're looking at 6 prototype communities to develop what that role may look like. And that's going to involve a lot of partnership working with the health authorities, and understanding how paramedics can integrate even further into interdisciplinary health teams, and how by having an ACP in those communities can actually support our pre-hospital responses, and even our interfacility transfer work by having a higher level of skill available to those communities. So overall, in rural and remote, we know that our current on-call system is not a sustainable model in the long term. We've been living and fighting with a recruitment and retention issue for many, many, many years, and we need to do something to change that. And the realistic way of doing that is by having paramedics do more. The bit here is we have been maybe typecast by the health system as being the people who sit around and wait until there's a 911 call and then we go. That's not sustainable for us at all within the system, but particularly in these smaller communities, we have to go and have a valuable clinical contribution to these communities. And we're starting to develop ideas in terms of how we can do that more effectively. So finally, I'm just going to talk a little bit around some of the other things that we've been adding into our system, just for awareness purposes. As you may be aware, as part of the Action Plan funding, we were able to inject some additional resources, some additional full-time paramedic positions around the province, and we wanted to do that in a way that targeted the right areas, those that had the most need. So we've had quite a complex and involved engagement process, pretty much in line with the culture that I talked about up front, where we've been assessing evidence around where our demand is, how best we can meet that, but engaging people who are involved in those areas for their experience of what they need and what would make a difference to their communities. So we've had working groups involving unit chiefs, local leadership, union leadership, to work our way through these problems. And as always, you know, they say, what is it? Diamonds are forged in the heat of the volcano. These very passionate individuals come and they are committed to improving things for their community, and that has been a really fantastic way to ensure that we deliver a solution which not only looks good on paper, but is as good as we can do in terms of implementing it as well. And then we continue that with those individuals so that they're fully looped into what the impact of that change has been. We keep going with evaluation and feedback and listen to what their experience is of that change. So overall, we've been able to add resources. We've reviewed at least 40 different communities now in BC through this process. We've added 115 regular paramedic positions, and we've also been able to add some into dispatch to help us with the overall call volume growth that we've been seeing over the last few years. Now, out of that process came as many questions as answers, as you'd expect, and one of those questions has been really, how do we best use the resources that we have? The best solution isn't always just to throw more resources at a problem. Sometimes the best solution is to figure out how we can use them more effectively. And so this raised a whole bunch of questions around how do we best position our ambulances, where do we know where that demand is going to be, how do we predict, how do we forecast it, how do we make sure that we staff things appropriately, how do we ensure that we assign work in a way that doesn't strip emergency coverage from one community or another, and how do we, I think of it as how do we have a better contract with our employees where we respect the demands of their work and we can figure that in our decision making. So managing things like fatigue, balancing workload across different teams, things like that becomes an important part to engaging our workforce and letting them know that we're trying to put their interests first. Now, out of that, again, stealing ideas from wherever we could get, we went to Alberta and looked at how they do things, and they have something that they call system status management, which is really looking at how do you predict the demand that's going to be coming up, both in the immediate, short and mid-term, and what actions can you take at different stages to be able to mitigate the risk of not having enough supply to meet the demand that you expect. So that's about making sure that we've got a good understanding of our system, where that demand comes from, that we staff and equip ambulances, that we get them out there, we get them into the right locations, and that we can cope with the variability that happens within a day. This is something that we've always struggled to do. We tend to treat every day the same. We ask our dispatchers to behave the same way regardless of whether they have 15 ambulances available or if they have none. And it puts them in a difficult situation because we don't manage our resources in that kind of systematic way. And so what we're looking at now, we've just been kicking off some working groups based around each of our dispatch centres, engaging representatives from our frontline paramedics as well, so that we can assess overall what should we be doing at different levels of system status. So clearly, if you're in a complete emergency response, you're not going along like you do on every other day going, oh yeah, everything's fine, and we'll just get through it. Like, we need to have some plans of how we deal with it. The other thing that came out from those studies was an understanding of how much, particularly in rural BC, our interfacility transfer work drives our system. In some areas, we were finding that in excess of 75–80% of the workload of our paramedic crews is doing interfacility transfers. And that's mainly because of the long distances that they have to drive to take patients between communities and get them access to healthcare services which don't exist in their own communities. So we've had to start looking at some different ways of approaching transfers so that we can ensure it doesn't impact our ability to provide emergency coverage into every community. So we have been running some trials in partnership with Interior Health, and I've left this example to the end because for me this is an example of how much our culture has changed in the last few years. Interior Health has been an absolutely fantastic partner, coming to the table with us, looking for common solutions to shared problems. They have the issue with transfers that if we're not there, they don't know how to staff their units, they don't know if a patient is going to need to stay somewhere overnight, they have patients moving at strange times of day or night, it doesn't suit them, and it makes it challenging for their clinical workflow in each of these departments when they don't know and they can't predict when patients are going to arrive and leave. So we've been trialling first and foremost on high volume routes with specific patient populations, a different approach to booking and managing transfers. So we have a huge number of patients that come from Kamloops into Kelowna specifically for the cardiac cath lab, to the point where on average we get 2 patients a day. So we've just started small and we said we'll give you a dedicated resource that we use every day to take one of those patients into Kelowna, but they are then there at a predictable return time for that patient to go back to Kamloops. And by doing that, we've managed to increase the number of patients that are pre-booked the day before, which gives us predictability around the demand that we need to meet. It's allowed our crews to meet virtually 100% pick-up and drop-off times within the system, which was absolutely unheard of in the past. And it's allowed our crews to stop being caught in either shift overruns or driving long distances without a patient, which means we're using our resources more effectively. And what we're beginning to learn from the early results of this trial is that this is really helping the cath lab manage their patient flow, and they are seeing fewer overruns at the end of the shift. Their overtime for their nurses in the cath lab has dropped significantly since we started doing this, and this has been, I think, a really good example of that collaborative working. Now, building on that, what this also opened up was the opportunity for some clinical change. So some of you may be familiar around vascular compression bands, sometimes called radial bands or TR bands. So the cardiac cath lab applies this dressing after the procedure. And in the past, patients who've been wearing one of these, which is the majority of patients I understand from who are discharged from the cath lab, they either have to wait in recovery in the cath lab until it can be removed, which was leading to patient turnaround times of longer than 4 hours in the cath lab, or a heart team had to accompany that patient, which the patient is not really high acuity, but they were the only people. So we've now, because we have this dedicated resource moving the cardiac cath lab patients, we've now had a targeted group of paramedics that we've been able to train in this particular device, and we are now seeing significant drops in patient turnaround times at the cath lab. So the cath lab is super happy about it. Our paramedics feel really engaged with this. There's been some great work done through our clinical and our learning departments to get this up and running. And this is the outcome that we get. These are the first 2 paramedics who did our training in this new device. Dorian and Tracy, I think their names are. And they were so excited about doing this that they actually took this photograph themselves and sent it to us. They were so proud to be the first people to do something new in this organization. And they had gone through a bit of online training in the cath lab, supervised by an educator, but they had been given a tour of the cath lab by the interior health nursing staff. They had seen a procedure from start to finish. They had, you know, as you can kind of see here, there's real interaction between the two teams. And hopefully closing the circle of this presentation, this is the cultural change. Because when we did our evaluation and we went and spoke to the individuals who've been involved in this trial so far, what did the cardiac cath lab nurses say? They said, this has been absolutely great because we can get your paramedics back before the end of their shift. And what happened when we spoke to the paramedics is they said, this has been fantastic because the cardiac cath lab nurses can get off time and don't have to hang around on overtime. That is, to me, the biggest thing that we are changing as an organisation is through this partnership working. We're having people, teams created, relationships created that are going to have significant impact for this patient population and the health system as a whole. So it's been a brief whistle-stop tour. I know, sorry, I kind of overran. I wasn't really given much chance with 10 minutes in there, but hopefully that's been of interest, and I'm going to be sticking around for a little while if you have any questions. We can probably take offline.